Good evening, friends, and welcome to Tuesday's masterclass in critical care medicine from Yashoda Hospitals in association with Hyderabad ISCCM chapter. So we bring forth an interesting exam topics which are hosted by senior seasoned clinician and examiners, which definitely gets benefited by so many students across India. So today's topic of discussion is infective endocarditis. For this, I would like to invite Dr. N. Ramakrishnan, sir, who is a Senior Consultant and Director of Critical Care Services at Apollo Hospitals, Chennai. And Dr. Khusrav Bajan, sir, he is the Senior Consultant and Intensivist and Physician himself, and at PD Hinduja Hospitals, Mumbai. So for today's topic, I would like to invite Dr. Srikanth and Dr. Shilpa. Both are DrNb Critical Care Medicine students at Yashoda Hospitals, Malakpet. So we will proceed with the discussion. So Dr. Srikanth and Shilpa, please start your presentation.
Good evening, sir.
Good evening. Please go ahead, please.
You have to share your slides if you have.
Yes, sir. Sir, is it visible, sir?
Yeah. Go ahead.
Yes, sir. Sir, good evening, sir. Myself, Dr. Srikanth, sir. And my co-PG, Dr. Shilpa, sir.
Good evening. Go ahead.
Yeah, you can proceed with the case.
Actually, the slides are not moving here, sir. 1 second, sir. Sir, is it visible, sir?
Yes.
Sir, we encountered a 45 years old female patient with nil comorbids. She came to the hospital with a complaint of fever, altered behavior, and shortness of breath. History of presenting illness. Patient had complained of fever from last 1 week.
I'm sorry. Before you proceed, fever, altered mentation, and shortness of breath. Only 2 or 3 diagnoses differential.
Yes, sir. Fever with altered behavior suggests of acute meningitis, sir. Or can be acute any brain abscess or any tropical related infection or a viral infection causing a CNS infection. And fever with altered behavior and shortness of breath, it can be a spectrum of any tropical infection or a viral fever, sir.
Or it could be pneumonia or
Exactly.
It can also be urosepsis
or acute heart failure.
So any sepsis, because we know that the quick SOFA includes altered mentation. So you
Yes.
can enumerate all, but pneumonias, meningitis, abscesses. Yeah, sorry. Proceed.
Yes. Fever of since 1 week, sir. She was having high-grade fever. There is an intermittent relief with taking the paracetamol. But fever is associated with chills, severe body pains, and generalized weakness. And after 5 days of the fever, patient family noted there is altered behavior from last 2 days, and difficulty in orientation to the time, sometimes irrelevant talk, and followed by shortness of breath of last 1 day. She was most of the time because of fever was taking the bed rest, but they noticed that while they are moving to the washroom or general illness, patient was having they have noted shortness of breath from last 1 day. So it was the NYHA grade 3, sir.
In general, we don't do NYHA grading for all breathlessness. I mean, it is usually only for patients with cardiac, CHF. That's where you talk about NYHA grade and paroxysmal nocturnal dyspnea and all that. So that's a little bit more into medicine. I didn't want to get that, but that's not a relevant way of stating it in a critical care examination.
Yes, sir. Can I proceed, sir? So there was no history of any vomiting, sir. There is no history of any seizures, any giddiness, or any loss of consciousness. There was no history of any ear pain or any ear discharge. There was no history of any cough or chest pain, palpitations, and pedal edema.
Why did you ask about ear discharge?
Sir, any ear infections, it is because it is near to the brain. It can be a source of infection causing the meningitis. So otitis media can spread to the brain.
Okay.
So past history, sir, there was no history of any comorbidities, and she was not on any regular medication. She was a housewife, 2 female children, was normal delivery, a regular menstrual history, and regular bowel and bladder habits were prior to this sepsis were regular. Family history, there's nothing significant.
Can you
So
give 2-sentence kind of summary on this whole history? It's very simple. So what would you say?
Sir, 45 years old female with nil comorbidities and not on any regular medication. Acute presentation of the fever of 1 week followed by altered behavior for 4 days followed by onset of shortness of breath. So fever SOB with altermentation indicates a sepsis as the cause of symptomatology, sir. Secondary to source of sepsis can be tropical fever, pneumonia, or a urinary tract infection, most commonly in the female.
Okay, I mean, I wouldn't even get that far. Your initial part was correct where you said 45 or 47-year-old female with no significant comorbidities presenting with fever, shortness of breath, and altered mentation, and appears to have sepsis of unclear source. Correct?
Yes, sir.
Exactly what you're dealing. All right.
Also mention drug toxicity. Sometimes they may be given or taking some drugs which might lead to all these 3 symptoms. So don't only talk about infections, but keep a little broader perspective.
Yes, sir. Can I proceed, sir?
Yeah. Go ahead.
So on examination, initial examination, her airway was patent, sir. She was having tachypnea respiratory of 26, with saturation of lower normals at 92%. There was equal air entry bilaterally. There was fine cryptations were noted on auscultation. BP on 100/60 with tachycardia, 130 beats per minute, regular. There was an auscultation. There was a systolic murmur is heard in the mitral area, and JVP was not elevated, sir, at the time of examination. And initial sugars were 112 milligram per deciliter. She was a bit irritable, moving all limbs, and pupils are bilateral normal size and equal in reacting to light. And she was febrile on arrival to the hospital with 101 degrees Fahrenheit. And clinically, patient has a pallor. There is no significant icterus. There was no cyanosis, clubbing, pedal edema, or significant generalized lymphadenopathy. On examination, there were reddish macular lesions noted over the both forearms and the both lower limbs, which were not blanching to the pressure.
So I don't think RBS should be part of the examination. It's a lab test. So you may want to put it as a, separate this thing, not in the examination. And when you have a pitical rash on the palms and the soles of the foot, which is the first diagnosis you would think of in India? So it would be dengue fever because that would give you a glove and stock kind of a rash. Yes. So whenever you talk of petechiae, you need to be very specific because fever and rash becomes a syndromic kind of a approach. And like you have fever with encephalitis, fever with rash, fever with lymphadenopathy. So you need to be a little more particular about the petechiae that you are describing.
Yes. So in systemic examination, she was agitated and restless, sir, confused, not oriented to time and place. She was having irrelevant talk. She was moving all limbs. There was neck stiffness was present at the time of examination. GCS is E4, V4, and M5. On respiratory examination and inspection, there were no visible any swellings or pulsations or any notable chest wall deformity. There were symmetrical movements and regular movements of bilateral chest. There was a bilateral equal air entry and fine cryptations were present. Serious examination.
Can I interrupt? When you say neck stiffness, aren't you supposed to do all the other signs of neck stiffness to confirm, or you will talk about it later? So when you say neck stiffness, you need to tell us the Kernick sign and all the other signs that you might want to do, because people can have a spondylosis and have neck stiffness too.
Yes, sir. Actually, on the initial presentation, we could see the neck stiffness, sir. But Brudski signs and Kernick sign, we are little difficult, sir, as patient was very irritable.
Oh.
So,
So
we could
always
not-
mention that. I completely agree, but mention neck stiffness was positive, but because of restlessness, we could not evaluate further. Anybody with fever and unconsciousness and neck stiffness, if not meningitis, what is your immediate differential? If not meningoencephalitis, which other condition gives rise to neck stiffness, which is dangerous?
Any subarachnoid hemorrhage condition.
Excellent. Subarachnoid hemorrhage. So you must always keep everything in mind and give your examinations as per that. Go ahead. Sorry.
So, CVS examination, inspection, palpation findings are similar, sir. And there we noticed the apex beat in the normal position in the left fifth intercostal space. There were no palpable thrills. There was a systolic murmur was heard in the mitral area, sir. It was actually patient was having severe tachycardia, so we could not appreciate very well the. We can identify the murmur, but we cannot time it whether it is a pansystolic or mixed systolic. JVP was not elevated. Her abdomen, she was having soft, no guarding or rigidity, and there was no arachnomegaly.
Rama, would we want this so much of examination, or they just give us a line or two?
I was actually just going to say that I'm very impressed if you did all of this, really. I mean, because how often in an ICU do you really look for a palpable thrill?
Yeah.
Speed? Like, it's one thing, for you to make a full presentation, but in the DrNb exam, as we were initially discussing, it's a short time. You get only 20 minutes for the entire case presentation and the questions. So if you spend too long on this, and I know this is a master class and the intention is different, but I'm just telling you from an exam standpoint, you need to be very quick on this. You can just say that the examination was suggestive of a systolic murmur and nothing else or whatever, and move on rather than spending too long. And fortunately or unfortunately, examiners have a tendency to latch on to something if they like it. Okay. For example, if somebody loves listening to murmurs, he can spend the next 1 hour talking to you on murmur questions. And similarly, like if you are saying thrills and stuff, they can start talking about thrills. So be cautious when you're presenting on what is relevant and what you are comfortable with. And if he really makes you go to the bedside and asks you to do all of this, are you comfortable? Okay.
Absolutely. So you could just say neck stiffness present, murmur heard, and rest of the this thing was unremarkable. You have to move on. Otherwise, this is not a medicine case. It is a critical care case.
Yes.
I'm sure there's a lot more fun coming around.
Yeah.
So provisional diagnosis, sir, at the end of history and the clinical examination, a case of a sepsis with MODS, multi-organ dysfunction. Source of sepsis can be a spectrum of the tropical fever, an acute viral or bacterial meningitis. Another can be a pneumonia.
If I ask you in order of your decision, which is your first diagnosis?
It is an acute meningitis, sir.
Okay, I would agree. If somebody has neck stiffness, altered mental status, and is having a high-grade fever, that would be my first diagnosis too. Okay, which one would be second?
Pneumonia, sir.
Pneumonia.
Yeah. So never give 8 or 10 differentials. This is not a theory exam. So you should give 3, 4, at the most 5. And as Dr. Rama is saying, it should be in the order of preference. So I wouldn't say acute heart failure because of anemia. You've not even got your hemoglobin, or pulmonary thromboembolism is not at all a diagnosis differential here. Correct, Rama? So don't give a bookish 10 differentials. Just say meningitis, pneumonia, endocarditis.
Yes, sir.
And tropical is always possible in India, so you can add that. But I would stick to these 3 or 4.
Yes, sir. Sir, initial evaluation, we suggested to do like an ECG. to see any STT changes, suggest of any myocardial infarction, and TROP-I to rule out the reason for acute onset of SOB, ABG to identify presence of any significant metabolic acidosis or hypoxia as the patient is having tachypnea. To rule out hypoglycemia causing her altered sensorium, blood glucose, whether high or hypoglycemia, complete blood count to know the hemoglobin differential count and platelet levels, renal function test to it may be newly identified acute kidney injury or background of CKD to know the electrolytes and creatinine level, coagulation profile as we are suspecting case of meningitis to proceed with the lumbar puncture and CSF analysis to know the values, liver function test, any transaminitis which is spectrum of the tropical infection, and also blood cultures as a part of sepsis workup. And since patient came from a rural background, to identify the tropical fevers. Since patient came with the fever with meningitis, so fever with altered sensorium, the CT imaging to rule out any intracranial bleed or any mass or any raised ICP features. CT test as the patient came with the SOB to identify any pneumonia or effusion-like conditions. Echo, since we heard a systolic murmur, to identify any regurgitation as well as to assess the LV function. Ultrasound and abdominal pelvis to identify any source of infection. Maybe pyelonephritis or cystitis.
Again, this is extremely thorough, but I would not read out all. You would just probably first say before even investigations that we resuscitated the patient. We gave him IV fluids. We looked after the airway. I mean, he was talking, he or she was talking, and the breathing was settled. So we gave them oxygen and we also did the investigations. And I would say blood culture was collected, CBC was sent, and we were planning a CT scan, and we did an echo and an ultrasound. I would just say it in 2 sentences rather than actually reading through.
So even to add further, I would say something like blood tests were done with a focus of identifying the reasons for infection, the breathlessness, and the altered mental status, right? That's exactly what you've done.
Yes.
All of whatever you for this blood glucose is all summarized in those 2 sentences.
Absolutely. And if you wanted to add, you could say a pro-BNP because the patient was breathless. You've not mentioned creatinine here. Yeah, renal function. So you can just say all the other general body profile was sent. And as Dr. Rama was saying, then specific for the diagnosis, I would have loved to do a 2D echo, a ultrasound, and a CT scan.
Yes. So initial ECG showed sinus tachycardia, sir. There were no acute STT changes. ABG, it was done with 10 liters of oxygen support. pH showing acidosis, sir. pH of 7.31 with bicarb of 14, serum bases of -8, suggest of metabolic acidosis with compensation, and lactates of 3.0. Anion gap is 26, sir, with serum sodium value of 142 and chloride of 101. It's a case of high anion gap metabolic acidosis.
What is
So
very
point of care,
shockingly wrong in this ABG, which you have done wrong? Do you want a PO2 of 262? Do you want to give 10 liters to this patient who was saturating at 92%? So you don't want to do that, right? So your new normal is 94%, not 100% saturation. So you would not be giving 10 liters of oxygen. You would just give 1 or 2 liters to try and maintain a saturation of 94 or a PO2 above 60. So you do not show PO2s of 262. You may have done it in reality, but don't do these mistakes.
Yes.
And when you say, when you harped on a high anion gap, give us very quickly 3 or 4 causes of high anion gap acidosis.
Diabetic
Shilpa,
ketoacidosis.
you can answer this.
Diabetic ketoacidosis, sir.
Diabetic.
And
Why don't you follow a mnemonic? I don't like mnemonics, but here you can follow clumpies or mud piles, right?
With the
So that you
knowledge.
don't forget. Can you tell me now or should we say it later?
mud piles, sir.
Ethanol, sir. Uremia.
No, go in the order, na?
Yes.
Methanol and uremia and these diabetic ketoacidosis. paraldehyde poisoning and isoniazide poisoning and lactic acidosis and
Ethylene glycol.
ethylene glycol.
Rama,
and
I'll be back in a second.
So point of care ultrasound was done, sir. It was showing good LV function. There was no RE/RV dilatation. The mitral regurgitation jet we have noticed, IVs was collapsing. There were no significant pericardial or pleural effusion. There were B lines were present, and there was no shred sign.
What is
Sir?
What is shed sign? Sir is asking you.
It indicates presence of sign of pneumonia, sir. Whenever there is inhomogeneous serrations were present in the subpleural level, so it indicates consolidation on those parts, suggestion of pneumonia.
Are you comfortable identifying it?
At least in lobar consolidations, we can identify that it may not be bronchopneumonia.
Is it sensitive or specific?
Sir?
Is it sensitive for diagnosing pneumonia or is it specific for diagnosing pneumonia? Either one?
Sensitive, sir.
Not really. And when you say IVC collapsing, you should mention that this is on a non-ventilated patient. So I would take it with a pinch of salt.
Yes,
When you're
sir.
talking of focus, be very specific because nowadays that's your new tool.
Yes.
So don't give too much information. You just say what you are looking for. So you can't give me ABC of focus.
Not ventilated.
Non-ventilated.
Non-ventilated.
IVC collapsibility cannot be trusted so much. So you
Yes,
have to say it's a non-ventilated patient and therefore I can't depend upon the IVC collapsibility.
Yes, sir.
Plus, as Sir is saying, no shed sign, you have to identify. When you say B lines, you have to say how many of them, plenty of them, not there, and interpret. So since B lines was present, probably what could it be?
Pulmonary edema.
No, so you have to say interstitial syndrome.
Interstitial.
And then say in this case, it could be pulmonary edema. When you talk about focus, please be very specific. What you are looking for and what are your signs. Don't just give A, B, C, D. Yeah. Okay.
Sir, we have started after collecting the blood cultures. Sir, we have started an empirical antibiotic therapy. Gave an injection, ceftriaxone 2 grams IV start.
Okay. What was your first diagnosis here?
Acute meningitis, sir.
Meningitis.
What meningitis are you suspecting?
Acute bacterial meningitis.
If it is bacterial meningitis, what should be the first thing you give?
Bacterial meningitis. First,
Ceftriaxone, sir.
ceftriaxone.
Yeah, that's the antibiotic. Anything else you want to give?
Steroid. Dexamethasone steroid is indicated. So 30 minutes before giving the drug, dexamethasone should have been given.
I mean, see, here
Along with the antibiotic.
you also mentioned about some petechial hemorrhages. Potentially, this could be meningococcal sepsis.
Yes, sir.
Discussing infective endocarditis today, and we're all heading that way. But when the patient is in real life, it could be meningococcal meningitis. So you need to make sure that you give dexamethasone and then give your 2 grams of ceftriaxone that you want. Okay.
Yeah. And since meningitis is your first diagnosis, differential so far, you've not even mentioned a lumbar puncture.
Yes, sir. Next we are actually after.
Oh, so you've given ceftriaxone without a lumbar puncture. You can say, okay, I would have done a lumbar puncture. Since you are on it, tell us quickly the 1 hour sepsis bundles that you would do in suspected infections like these. What is the 1 hour sepsis bundle? What are the 5 things?
Sir, first, fluid resuscitation, sir.
Yeah.
Fluid resuscitation and obtaining the cultures, blood cultures.
Okay.
And antibiotic as early as possible. Antibiotic as
Okay.
early as possible, and targeting the resuscitation for lactate levels, sir. Measuring the lactate levels.
Okay. and refractory hypotension give vasopressors.
Noradrenaline.
So
Early-
you collect 2 and you give 3. You collect cultures, you may do a lumbar puncture for the diagnosis, and you will collect lactates. And you will give fluids, be specific. You will give 30 mils per kg or whatever. You will, if refractory, then you would start vasopressors. And if not, then you would also give antibiotics within 1 hour. So be a little specific on this. In meningitis, if I'm not wrong, it is 30 minutes of antibiotics. That's one area where you need to give your antibiotics fast. So make us feel, till now I'm not feeling that it is more of an ICU case. Make us feel that we followed the guidelines, we did all this, we sent the cultures rather than renal profile and all that. We did the sepsis 1 hour bundle and we gave the antibiotics within 20 minutes or so. And we prepared for a lumbar puncture. It doesn't have to be immediate.
Yes.
Go on, please.
So immediately after giving an antibiotic, the patient was taken for an imaging. So imaging showed a hypotensity seen in the multi-arterial territory, that is right insular perisylvian region and left posterior temporal region. And there is no imaging suggest of any raised ICP features. Followed by, since patient came with shortness of breath, the screening CT lung window was done. It was showing diffuse brown glass apoptosis in both lung fields, mostly suggestive of pulmonary edema. And in the lower sections, they have noticed a splenomegaly with multiple hypotensities in the spleen. So an ultrasound abdomen pelvis was done, sir. It was showing there is a hypoechoic ecotexture present in both kidneys, and there is mild hepatosplenomegaly.
So this patient has got what diagnosis now? Pyelonephritis with acute stroke.
He is having a hypoechoic lesions in brain, sir, in kidney as well as in the spleen area.
That was a very straightforward question. Okay, we don't want you to again tell us about what the findings were. We want your interpretation of the case. That's exactly.
That
The multiple arterial infarcts were present, sir. So lesions are suggestive of
septic emboli.
Suggestive of septic
Septic
emboli
emboli.
in the systemic circulation.
Why do you say septic emboli? It's embolic. That's all. How do you know it's septic embolic?
Yes, sir, embolic.
You had a murmur and there could be cardioembolic. There could be a atrial fibrillation you have missed. You mentioned sinus tachycardia. So you
Yes,
could
sir.
have missed an AF.
Yes, sir.
So keep your avenues open about diagnosis. So at this stage, we also thought of pyelonephritis, acute stroke, but we ruled it out. Don't be focused on septic emboli as sir is saying.
Yes. So 2D echo, which was showing tachycardia was there, sir. They have noticed a mitral reflex collapse with severe MR. There was a good LV function. There were no any RA-RV dilatation. There was no LV clot or no pulmonary embolism. Pericardial effusion.
So during your focus, you mentioned about some heart findings. Did you look for the MR? Do you do that in your focus?
Yes, we do.
Yes, sir. Just we check the any regurgitation that is there by color Doppler, sir, whenever it is possible.
Sorry,
See,
the last was like
sir, we check the color jet, sir. We don't quantify, sir. Just qualitatively we see whether any regurgitation was there in the left-sided circulation.
By putting on the Doppler
Color flow, sir.
Doppler color flow, we see for any regurgitation.
you didn't find it on your focus because I didn't see that in your report. Correct?
I have mentioned, sir.
On focus, you did not mention, nah?
Oh, there is
Nothing. Good LV function. See?
okay. That's fine.
Mitral leak.
Just mention my. Okay. I missed that. Okay.
So on the day 1 lab, sir, initially patient was having anemia 6.9 NAF per deciliter, high total count with predominantly neutrophils and left side shift and thrombocytopenia. Peripheral smear showing a normocytic normochromic picture with cystocytes were not seen. The tropical fever workup was negative. The creatinine is 2.5, sir, on higher side. Electrolytes are within normal limits, and As an inflammatory marker, CRP is raised. Pro-BNP was high, 25, more than 25,000, and TROP-I came positive.
So you have bicytopenia and you have leukocytosis.
Yes, sir.
So you might want to just tell us a differential.
It can be a tropical fever infection, sir. It can be malaria, first thing. Another differential can be dengue fever.
Dengue, no. Dengue, you have hematocrit high. So don't just mention 1, 2, 3, 4 of tropical. Huh? So you can even think of very widely some sort of a lymphoma which is affecting the patient.
We'll see for
Okay,
any.
go ahead. Yeah, sure.
So complete urine examination, it was showing a pus cells of 10 to 15, sir, and RBC 30 to 40 in high power field, suggestive of a microscopic hematuria. So at the end of the day, in the ICU, the patient has still persistent altered sensorium, and she was going to hypotension and needed vasopressors. Respiratory distress.
You have still not told us how much fluids you have given. I didn't hear anything about resuscitation so far, only investigations and tests like imaging. So you should have said now, which I told you in the surviving sepsis thing. Okay, we gave 1 liter, we gave 2 liters, whatever, as per the weight. And despite that, there was hypotension, hence vasopressors were started. And which one? You can't just broadly say. So you can say noradrenaline or whatever.
So we resuscitated with 20 ml per kg, sir. Normal saline was given around 1 liter. After that, even after coming to the ICU, the BPs came below the 100/60. So we started a noradrenaline at 0.5 mics per kg per minute, sir. And
you actually gave 13 ml per kilogram in a patient whom you are suspecting heart failure? Because you mentioned about some crackles, you mentioned about the BNP being high, you mentioned about so many other things right in the CT showing interstitial changes. I think you mentioned some curly lines, all of those. So I would have been hesitant to give 30 ml per kilogram. Did you give it?
We gave it 20 ml per kg, sir. Around 1 liter was given.
You can't change what you said. So you have to say, as we are trying to point out, you can't say 30 mils per kg for every patient. Here you were suspecting heart failure. You said NYHA 3-4. I mean, you can't be giving fluids. Huh? So here I asked you purposefully and we...
Okay.
Yeah, okay.
This is a learning experience.
Yeah.
So relax and be honest on what was done, what wasn't done. It's okay. I mean, we are here to learn from each other on this. So don't worry. This is not the real exam.
Yes, sir.
Go ahead.
So the patient, after coming to the ICU, patient had tachypnea has increased, sir, and the serial ABG showed worsening of the metabolic acidosis, and she was having oliguric around 5 to 10 ml per hour urine output. So in view of drowsiness, falling GCS, and requirement of moderate doses of noradrenaline at 0.5 micrograms per kg per minute, we have electively intubated her. And she was oliguric for almost more than 6 hours. So initiated in background of metabolic acidosis, we initiated a renal replacement therapy. And because of anemia, we have 1 minute of blood transfusion has been done, sir. And then lumbar puncture and CSF analysis is done.
Any
So
studies you are aware of for blood transfusions in the ICU? You gave only 1 unit here. So any studies you are aware of? At what would be a trigger to give a transfusion in septic patients or in cardiac patients in the ICU?
Cardiac patient, we usually target around 9 grams per deciliter, sir. Or if not cardiac, then usually 8 grams.
7. So you should know the studies. Okay, go ahead.
CSF analysis showed and cross-examination the appearance is like easy, sir. There were 900 cells with predominant neutrophils, and sugars were 51 milligram per deciliter. At the time, GRBS was 140. There was a high protein level, 155 milligram per deciliter, and there were many pus cells of So CSF picture is suggest of a acute pyogenic meningitis, sir. So we started her in addition to ceftriaxone, vancomycin 1 gram.
Why was vanc added? What is a common organism you're trying to cover in acute pyogenic meningitis?
Streptococcus pneumoniae.
Streptococcus.
So why add vanc? Isn't ceftriaxone 2 grams 12 hourly sufficient? You have
Yes,
to
sir.
justify why you added vanc. You are right. I would have also added, but why?
MRSA can also be.
No, you are covering strep.
Yes.
So 30% of the strep in India are resistant to ceftriaxone.
Yes.
And therefore, in meningitis, you cannot take that risk. So you have to add vancomycin. And both the doses you've said stat only. You've not said we continued ceftriaxone 2 grams. Stat only you said. You didn't say we gave it 12 hourly and vanc also 12 hourly.
This is the initial part, sir. I mean,
Yeah, sure. Absolutely right. But you have to justify why vanc. And the reason is 30% of our strep pneumonias are resistant to cephalosporins or penicillins.
Yes.
You add ampicillin.
Sir?
You add ampicillin.
Yes, sir. Listeria can also be one of the cause. We should add ampicillin 2 grams every 4th hourly.
Which group?
For listeria.
Yes, sir.
Why?
It is because ampicillin is has a good action on the listeria.
No. My question is, you mentioned about listeria. Let me word my question differently. Who are the people who are at risk for listeria meningitis?
So,
Elderly age group, sir.
You said 55, right?
45. Sir. Usually above 65, we tend to give that. It was empirical.
Rama, they are indirectly saying we are elderly. Yeah. Okay, go ahead.
So at the end of the day one, sir, we diagnosed a case of sepsis with MODS. Since the imaging was showing a multi-arterial tender infarct with a systolic murmur, and echo was showing a mitral regurgitation, and a left-sided tender, so suspected an infective endocarditis, though she doesn't have any risk factors. So another thing is an acute pyogenic meningitis based upon the CSF analysis and case of septic shock.
You never mentioned about a vegetation. You had done transthoracic echo and mentioned about mitral regurgitation. Was there a vegetation seen?
In an initial transthoracic echo, we couldn't make it out, sir.
Okay. Usually, is the transthoracic echo sensitive or specific?
More specific, sir. Sensitivity is only 30 to 40%.
It's almost 100%, right?
Yes.
How sensitive is it?
30 to 40%.
Transthoracic is 30.
More than that.
TE, sir, or TT?
TT.
TT, because the initial recommendation or the first test that you would do for a vegetation is actually a transthoracic. You don't jump into a transthoracic for everyone. Interest, the sensitivity is almost 70 to 75%, even on a transthoracic if somebody has a vegetation. Okay. And if it is transesophageal, what would be the sensitivity? Almost 90%.
Has to be higher, no?
Yes.
So what I'm trying to get at is that transthoracic is not bad. You know, it's 75%. So you can look at it first. Okay, move forward.
So by now you should have picked it up. That's what we are trying to say. 70-75% of them should be shown on picked up on transthoracic or 2D echo, what we call. So by the vegetation, despite a focus, despite an echo, was probably not picked up. It should have been.
If this was infective endocarditis, okay, what is the mechanism of the acute kidney injury in those?
Acute kidney injuries.
Why do they forget sepsis and all that here? That's not what I'm talking about. In infective endocarditis, why do people get?
Sir, it is embolization of the vegetations causing obstruction of the circulation. So, and
You listen to the question.
The mechanism of acute kidney injury in infective endocarditis is actually immunological.
glomerulonephritis, sir. It is because of immune complex deposition.
Very good.
That's what I was asking.
So it's a specific question. You know the answer, always come out with the right reason.
Yes.
Acha, now you are saying infective endocarditis. Do you have any Duke's criteria which are suggestive of infective endocarditis? At this point, you must mention Duke's criteria, even if we are not asking.
Yes, sir. She had a fever, sir, more than 38 degrees centigrade, and major arterial territory emboli were present. The brain, the spleen, the kidneys. Two of the minor criteria satisfies, sir.
All your multi-organ failure could be part of the sepsis and the hypotension. So I don't think that suggests any of your major and minor. Your major is, which are your two major? Fever more than 38 for about 3 to 5 days, and your echo showing vegetations or there are 4 criteria, 3 to 4 criteria. What are the criteria for a major criteria being positive for endocarditis?
The major are blood cultures for a typical organism responsible for infective endocarditis.
One is
That
blood
would be
culture. Fever will go as a minor criteria.
Yes.
So
Another
2
major
blood
criteria-
cultures will be major. And what are your echo findings as a major criteria?
Presence of vegetation, sir.
Yes,
Or
one.
yes, another can be in addition to the vegetation, there can be an abscesses. There
Very
can
good.
be,
Paravalvular abscesses.
paravalvular abscesses. It may be a pseudoaneurysm or presence of an intracardiac fistula, or in case of prosthetic valve, there may be two dehiscence of the partial dehiscence.
Excellent. And one more, which you found in your case, an acute unexplained regurgitation. So you have an acute severe MR. So you might actually say that the criteria is fulfilling.
Yes.
Yeah. Okay.
Just 1 second. There is a question from the audience on, is tea suggested even when a vegetation is seen in a transthoracic? What would you say?
Sir,
Question, sir.
sir,
Pardon, sir.
A transesophageal echocardiogram indicated even when the transthoracic echocardiogram is already showing a vegetation. Okay.
Simple question. Yeah.
Did you understand?
Sorry to say that, sir. The question is not clear, sir. Actually.
So you've got a vegetation on echo, but then do you still do a transthoracic, transesophageal?
No, sir.
That's what.
Not necessary. Not necessary. If other criteria is also meeting, then I think we should not be.
The initial part for a diagnosis,
But definitely-
to identify the complications related to the infective endocarditis, in the latter part it is needed, sir.
To get how much involvement and to further go for a surgical intervention if it is a large vegetation, based on how large the vegetation is and how severe the disease, and whether it is a prosthetic valve or it is a native valve also.
I think the simplest way to think about this is, once you have seen a vegetation on transthoracic echocardiogram, there's no doubt on the diagnosis. You've already made the diagnosis of infective endocarditis. Now, once you want an additional study, it is only to look for something more specific. If you are looking for a microabscess, if you are looking for a tear in the valve, there a transesophageal may be better than a transthoracic. So it is not necessary again for the diagnosis of infective endocarditis, but it may be necessary to identify the complications of infection.
Absolutely.
Okay.
Yes. So on day 2,
What was the predisposing, sorry to interrupt, what was the predisposing factor in this patient for endocarditis? Since it's our first differential here.
Actually,
What are the predisposing factors usually? Like you said,
Yes, sir.
otitis media for meningitis.
Yes, sir. It is usual predisposing factors are elderly age groups are more than 65 years. Male,
No.
it
Every
can be
elderly
prior-
doesn't get endocarditis. How common is endocarditis?
Yes, sir. Prior endocarditis Or
First time.
in this patient, sir, you were asking.
No. You said,
Ambulatory-
what are your predisposing factors for endocarditis?
Okay. Predisposing factors are already existing intracardiac any implants
Okay.
or then IV drug abuses
Very good.
and also catheterization, indwelling catheters, or if the patient is having some congenital heart disease bicuspid aortic valve,
So
aortic stent.
intracardiac problems or implants, very good. And one very common thing you've missed out. I gave you a hint. You said ENT for this, meningitis, so something close to that for endocarditis.
Dental hygiene.
Dental procedures.
Dental hygiene.
Yeah, very important.
Recent dental surgeries.
If dental
And,
procedures
some
lead to, if dental procedures lead to endocarditis, what is the commonest organism?
Streptococcus groups.
Have you heard of HACAC?
Has a good yes.
Yeah, so those are commensals which are there in the oral cavity, which would lead to that. Forget, yeah, it's okay. Move on.
Sir, on day 2, still she was on moderate doses of oratory requirement, sir. At 0.3 micrograms per kg per minute. The initial BF ratios were 250. There was a slight improvement, 300, but she had a persistent oliguric state. Slight improvement from 5 to 10 ml per hour to 10 to 15. A review 2-day echo was done in the ICU, sir. So it was suggested of a mitral valve prolapse, predominantly posterior mitral, and query there was a vegetation of the posterior mitral leaflet. In addition to the on day 1 blood cultures, another 3 sets of blood cultures were sent on day 2. And we have noticed there is a right foot, there was a discoloration was present, and it was cold to touch, and we could not appreciate very well the dorsalis pedis artery pulsations and posterior tibial pulsations on the left
What is the
side,
cause of
right
this?
side. It can be a septic emboli causing the obstruction, sir, as part of major arterial thrombus.
Less likely. What is the other term when you have a femoral artery occlusion? And you can see something else. Femoral, tibial. What are the complications of endocarditis?
Complications starting from the brain. Patient can have some intracerebral hemorrhages and brain abscesses, and coming to the lung, pleural effusions.
Anything else they can have in the brain? And the femoral artery?
Stroke.
Femoral artery.
Since you mentioned femoral foot discoloration, femoral artery and brain, something that can happen with endocarditis. They are better and they suddenly become unconscious. An endocarditis patient is improving with treatment and suddenly becomes unconscious. So what's
Mycotic
the
aneurysm.
mycotic aneurysm? Very good. Okay, so you can have a mycotic even in the femoral artery. More common than brain. Okay, go ahead. What are the other complications of endocarditis?
In the lungs, a patient can have pneumonia and pleural effusions and lung abscesses.
Septic pulmonary infarction.
And,
It's not called pneumonia or effusions, no.
Septic pulmonary infarction.
Pulmonary infarction.
One is septic emboli, one is mycotic aneurysm, then?
Renal infarction, splenic infarction.
Okay. They are against septic, you are saying?
Yes, sir. Immune complex deposition can cause a glomerulonephritis.
Very good.
Osseous nodes and rock spots.
That's a sign, no, beta. That's a sign. We are not talking of complications there. Multi-organ failure like this patient, glomerulonephritis, immunological, and many paravalvular leaks and heart failure, which you mentioned in your patient. So localized and then systemic. Okay, go ahead.
So bedside Doppler study was done, sir. It was suggested of right superficial from right papillary artery and posterior tibial artery. There was a narrowed dampened velocities were present both the right and left sided. suggest of an arterial obstruction, so narrowing. And on the day two, there was we could come down on there was an improvement in the PF ratios and we could come down on the FiO2 requirement. Acidosis, there was a slight improvement. Post RRT, the creatinine value has decreased, sir. Total counts are also decreased compared to day one. Post transfusion, hemoglobin improved to 8. But patient having a persistent thrombocytopenia.
Okay, one second. This is not infective endocarditis related, but 2 days you are having a PaO2 over 200. Why?
I know. You seem to be loving oxygen.
Okay, this is not related to endocarditis. I just wanted to bring that up to you. Before you move into more investigations, at this time, have you involved a cardiothoracic surgeon?
Yes, sir.
Yes, go here after
What do you think you should say?
and
Counts and stuff.
cardiac consultation.
Somebody who may need surgery, right?
Yes, sir.
Yeah, go ahead.
Also, you did not tell us why the renal replacement therapy was needed. You haven't shown us any creatinine.
Showed 1, 2.
He showed? Oh, sorry. I'm sorry about that. Yeah. Must have missed it.
Then it was 2.5 mg per DL, sir.
So which are the criteria you follow for renal replacement or for acute kidney injury currently in the ICU?
Sir, oligoanuric state, sir, severe metabolic acidosis. And,
Which criteria do you use? Rifle, Akin or something else?
KDIGO criteria.
So you should know that. You should know the criteria. Okay, go ahead. Sorry, I'm disturbing you a lot.
So the blood cultures reports which were sent on day one has came, sir. Which 2 sets we have sent. So it is a methicillin sensitive staph aureus.
Both of them showed the same pattern.
Yes, sir.
2 blood cultures showed MSSA.
Yes, sir.
Okay.
So the CSF culture that was sent initially was sterile, sir. The urine culture and ET culture were also sterile. After the blood cultures, since it is a methicillin sensitive staph aureus, so flucloxacin 2 grams IV every 4th hour was added, sir. So vancomycin was discontinued.
So now we are dealing with meningitis as well as endocarditis, right? So we
Yes.
presume whatever ceftriaxone and vanc is covering the meningitis. But
Yes, sir.
for endocarditis, could you elaborate what are the types of endocarditis and what are the other cultures that you might grow? Which is the common organism depending upon the types? Very
Yes, sir.
quickly.
Yes, sir. It can be based upon the type of the valve involved. It may be native valve endocarditis or a prosthetic valve endocarditis.
Very good.
Depending upon the chamber side involved, it can be a right-sided valvular endocarditis or a left-sided valvular endocarditis.
Right is common in?
Injection drug users as well as having any invasive lines. Maybe dialysis sheath, it may be a chemo port, it may be a PICC line, or these are the conditions, or having a transvenous pacemakers. These are the conditions, cardiac non-cardiac conditions where the right-sided involvement is more common. Another thing is another classification based upon the duration admitted. It can be an acute bacterial endocarditis or a subacute bacterial endocarditis.
Very
And
good.
another can be a community acquired endocarditis, or it can be a nosocomial or hospital acquired.
Excellent. Yeah. And now prosthetic valve as per duration, how do you divide it?
Sure, it is divided to 3, sir. Less than 2 months, 2 to 12 months, or more than 12 months.
Excellent. So this is everything about it. Now you might want to just add what are the common organisms quickly in each.
So in a community acquired native valve endocarditis, sir, the most common is the streptococcus, Aedes streptococcus, followed by Staphylococcus aureus. In a hospital acquired
So let me correct you. The commonest is staph. It used to be strep 20 years ago, but because of IV drug use and all the unnecessary antibiotics being used, now we have staph as the commonest. So 30 to 35% is staph aureus, staph cons, etc. Then comes your strep. And the third organism?
So enterococcus.
Very good, excellent. And for prosthetic?
Staph aureus is most common.
Staph, gram negative.
Gram negative.
What happens after 1 year? The last group of prosthetic valve?
Same as the community acquired.
Same as community. Very good. Excellent. Yeah, go ahead.
Okay, let me ask a question regarding the blood cultures. You said you had sent 3 blood cultures initially, correct? And you showed the results of 2. But
That is on day 1, sir. Day 1, we have sent a part of sepsis protocol and initial contact with the patient. 2 sets of blood culture were sent, sir. On day 2, when a Dept 2D was done, so more of meningitis again, as per the meningitis, as per infective endocarditis protocol, we have sent 3 sets of blood cultures.
so what is the infective endocarditis protocol for blood cultures?
In case of an acute bacterial endocarditis, sir, we set 3 or more sets of blood cultures with each from 3 different venipunctures, preferably peripheral, with a time gap of 30 minutes of duration. In case of a subacute bacterial endocarditis, we send 2 samples. Maximum time gap between the 2 sets is 12
That's
hours.
okay. That's okay.
The ICU, you are suspecting infective endocarditis. I agree with you. 3 sets of cultures, 30 minutes apart, preferably from 3 different sites. Okay.
Yes.
Cultures. What is the blood volume that you would collect?
At least 10 ml volume, sir.
For each bottle.
Each bottle.
More. Okay.
10 or more.
30 ml in each bottle.
That's what they require usually, but often doesn't happen. But that's the volume that they would like to have. After the first set of blood cultures, when would you do a repeat blood culture?
After 48 hours, after the 48 to 72 hours.
48 to 72 hours. Then subsequently,
Till
We get the negative cultures so that we can plan the antibiotic course from that.
it's usually done every 48 to 72 hours until you get a negative culture. And usually the first set of cultures may turn positive early. And once you've initiated the antibiotic therapy, you're going to find that there may be a delay in your getting the positivity as well. Okay.
What are the causes of a blood culture being negative and still the patient has endocarditis?
one reason can be a prior receiving of antibiotic before taking.
Very good.
Second, it can be a slow growing organisms, a nutritional variant of streptococci, or some intracellular organisms like acid. So these are the 3 most
Very
common.
good. And a wrong technique,
Yes, sir. Wrong.
as
technique.
we just discussed. Yeah.
Yes.
And also maybe fungal sometimes.
Yes.
Very good. Excellent. Yeah. Go ahead.
So on day 3, compared to on the day 1, the irritability was decreased. Even the patient is on ventilator, she was trying to obey the commands. And we came to low dose of noradrenaline, 0.1 mics per kg per minute. Compared to day 1, the frequency of fever episodes has decreased. There is slow improvement in the urine output to 30 ml per hour. And ABG was also showing a resolving metabolic acidosis. There was still discoloration was present on the right lip, foot, and was cold to touch. There on day 2, there was a lab report showing hemoglobin of 7. So we have transferred another unit of bloods. So these were the labs on day 3. FiO2 was reduced to 40% and ABG showing acidosis improvement. And there was a decrease in the total leukocyte count. And creatinine, only on day 1 we have initiated a renal replacement therapy, sir. And day 2, day 3, there was no renal replacement therapy. On day 4, transthoracic echo was done, sir. It was showing a vegetation.
Transesophageal.
Transesophageal echocardiogram done. It was showing a vegetation on the mitral valve. The patient was conscious and was obeying, and she was off narrative support, and she was tolerated the spontaneous breathing time. She was extubated. There was improvement in the urine output to almost normal level with no acidosis. The CT peripheral angiogram was done on day 4. It was showing infarcts in the multiple organs in both lower limbs.
So when you want, can we go back? Yeah. So when you talk about a transesophageal, Dr. Rama already asked you why when you do it when you have already seen vegetations. So here you need to tell us more about the patient than just the vegetation. So what was the size? Was there a paravalvular leak? What was the regurgitation? Had it increased? And is that important?
Yes, sir.
Why?
It becomes if any size in the increase in the size, large vegetations on the left side we take is more than 10 mm, sir, and the right side it is more than 20 mm. These are the cases where there are more chances of having embolism. And another thing is quantification of the regurgitation and the LV function. If the diagnosis is in heart failure, it becomes an indication for surgical intervention. And
So,
to identify.
tell me 5-6 causes of, indications for surgery.
One is presence of heart failure, sir. Second is presence of intracardiac complications in the form of large vegetations, presence of paravalvular leaks and pseudoaneurysms and valve rupture. And persistent, in spite of starting the antibiotic therapy, patient is having persistent fever spikes and the repeat blood culture showing persistent growth of resistant organisms.
Yeah. So I'll give you a very easy mnemonic here, though again, I'm not very fond of it. It's called as fun hearts. So also the organisms matter. Okay. So the fun stands for the fungal. So one is fungal infections, you usually need surgery. Then hearts, H stands for heart failure, which you mentioned. Valvular dysfunction, which you mentioned with that. E stands for your enterococcus.
Yes, sir.
Then A stands for your abscesses. So if you have paravalvular abscesses, then that becomes a indication. Okay. Then R stands for rhythm. So if you have any AV blocks, after that comes your T, and T is the time. So as you mentioned, fever after correct antibiotics, 5 days if it persists. And then S is for the size. So more than 10 millimeters. So if you remember fun hearts, then you would know exactly when to involve a cardiothoracic. As Dr. Rama told you, you should have involved them much earlier.
So this was the TE report, sir. It was showing large vegetations on the both reflex of mitral valve with severe mitral regurgitation. There were not suggest of any abscess or intracardiac complications on the initial transesophageal echocardiogram. And this is a peripheral angiography which was done. It was showing infarcts in the spleen, infarcts in the right kidney. There was a filling defect in the both the right and left sided in the below popliteal area. So on day 4, we have extubated the patient. ABG parameters, there was no significant acidosis. You know, also very the improvement. So
the one thing that's concerning here is the WBC count is going up.
On day 4, it was shown on higher sides.
Sorry?
Yes, sir. 20,510, sir. Actually, it became high on that day.
So that's wrong, na? That's a concern as sir.
Yes.
So something else is going on, we don't know.
Yes, sir.
Maybe the meningitis is worse. Maybe your abscesses are developing. Maybe your antibiotic choice is wrong. Maybe your dose is wrong. So all that should come up.
Yes, sir.
I know you're focusing on blood tests. But one other thing you should have done by day 4 is repeating ECGs. He already told you about heart blocks. Okay, the only way to determine that is by doing 12 lead ECGs at least once in 2 days.
Serial ECGs were being done, sir, on daily.
Was mentioned. So
yes. So her sensory was better, sir. Vitals was stable on day 5. Actually, patient was scheduled for right lower lobe embolectomy, but because of the financial issues and they went and left against medical advice by the end of day 5.
That's the easy way to end a case. But in case this patient stayed with you longer, what would be your plan?
Surgery as early as possible, sir, because the patient is hemodynamically stable and it was a large vegetation and patient is in acute heart failure. So we would like to go ahead with the surgery first, cardiac surgery.
So you would not have probably extubated the patient and you would have discussed with the surgeon before extubating the patient. So don't always. So what are your criteria for extubation and weaning in an ICU?
First thing, the primary reason.
Exactly. So was this treated? It was not treated. So you all extubated him on day 4 when the primary condition is not under control. So I would say it's a wrong extubation.
So, did you talk to this patient why they left Lama, and were there any therapies that you offered when they were willing to go home?
No, so from day 3 onwards, they were discussing with us like regarding their financial constraints. So we advised for a government setup, but they said it is difficult for them to get a bed for that point of time. So we just extubated and told them to address as early as possible. So that is advice we gave from our side because they're not affordable to go to other corporate hospitals also.
But you don't extubate for Lama, you send them the way they are with a proper history.
Yes, sir.
All right. How long would you have given antibiotics? Forget the Lama. Okay.
Okay.
How long would you have kept this patient in the hospital? How long would you have given IV antibiotics?
Since it is an AT-ball infective endocarditis, we would like to continue for at least 4 to 6 weeks. Sir.
That's a wide range, 4 to 6 weeks.
Actually,
4 weeks.
we
Repeat cultures.
based upon we have repeated the blood culture, sir. On the day 4, the blood culture came sterile, sir. So from the day 4, we have to continue the therapy for another 4 weeks.
What would be the antibiotic you're going to give for 4 weeks?
So oxacillin 2 grams every 4th hour.
Okay. Does it have to be given intravenously, or can you switch to oral or intramuscular sometime?
But yes, sir, maybe after 2 weeks. But currently, the patient needs.
All real life questions, right? I mean, patients are going to ask you. They don't want to be in the hospital for 4 weeks if
Yes.
it's as an outpatient. Because here is a patient who's got extubate. I'm not saying that she's fine to go home. You know, she still has AKI, covering, she still needs antibiotic. All that is fine. But they might ask you, at what stage can I get things done at home that I don't need to be in a hospital for? Because intravenous antibiotic, theoretically, you can give it at home. You can give it as an outpatient, right?
Outpatient antimicrobial therapy can be started, sir.
Preferably IV, sir,
So
intravenous.
10 to 14 days is what sir is asking. 10 to 14 days would be IV. After that, you can switch to oral if there is a good response. You can't put a central line, right? Which one would you put? Already endocarditis, you don't want a right-sided now, correct? Secondly, you don't want to put a femoral because one leg is gone. So you will run short of IV access. One. Secondly, you need to change to oral. A trick question here is, once the culture is negative, any antibiotic you would start for sterility of the vegetation? So rifampicin is always added so that it doesn't recur, and it is always given after the culture is negative, 2 to 3 days later.
So Dr. Khusrav was asking about what access would you send them with? What would you use after they're ready to go home? How would you provide an intravenous access for them to get the medication? What are your options?
Access, venous access, very good. PICC line would be better options then.
We can repeat a normal peripheral venous access, sir. Why no peripheral venous access can be secured? Because we don't want to add another risk factor causing the right-sided endocarditis.
Okay, so PICC line is one, yes, but is there anything else that's come now that you can use? Something that's available. It is not a PICC line, but not just a peripheral IV. Have you seen midlines? Okay, there is something called a midline, shorter than a PICC line. You can use it in the arm. There's something called a mini midline, which you can even use in a forearm vein. Okay, because of what it's made of, it can be left longer than a venflon. Okay, so therefore you can use some of those if you want to give prolonged IV antibiotic. PICC lines, I agree with you. You're putting them at another risk. But if you need longer IV access, particularly somebody who's difficult to get peripheral IVs, you can put a midline or a mini midline. Somebody is asking whether you can give intramuscular. What do you think?
Can you stop sharing the screen so we can all?
Somebody's asked whether you can give intramuscular.
See, her thrombocytopenia is not fully recovered, sir, and daily pricking may be it may lead to hematoma formation. So better we go for IV.
And the dose here is very high. You give clocks 2 grams 4 hourly. So how often are you going to give intramuscular? So as Dr. Rama said, you can use a midline or a pick line.
Different story if you're having some other things like, gram positive, MRSA, if you're thinking of using Targocid, intramuscular, those kind of things are different. Teicoplanin, sorry, I shouldn't mention a brand name. So those are different stories, but to give something every 4 hours, even ceftriaxone, theoretically, if you're giving, you can give it intramuscularly, but not something every 4 hours in somebody who is already having thrombocytopenia and stuff. It's inappropriate. Okay, so I think we discussed about the presentation. We discussed about how you diagnose. There's only one other question that I have in the diagnosis. Other than the echo, is there any other imaging technique you can use for diagnosing endocarditis, the valve vegetation?
Yes, sir. In new Duke's criteria, they have included cardiac CT imaging to identify any paravalvular lesions, sir, along with in a prosthetic valve endocarditis to identify the activity around the prosthetic valve. 5-fluorodeoxide glucose PET CT and SPECT CT have been included in the new Duke's criteria.
Good. Yeah, very good. So those are some of the options. So we discussed about the imaging and the diagnostic options. We talked about blood cultures. We talked about initial empiric antibiotic therapy and what to tailor it to once you start getting the cultures. We talked about how often you repeat the cultures. We talked about complications, how you're monitoring as far as, like the serial ECGs, WBC counts, looking for, valvular problems, looking for, absence.
Excuse me.
Involving the surgeon early and identifying when they may need surgical repair. So those are the main aspects of infective endocarditis that you need to be aware of. And as we discussed, the case started off as something like a general sepsis discussion. I know we were focusing on infective endocarditis. So even in your examination, when you have a 20-minute, you can sometimes guide the examiner to ask you the questions that you know the answers for. Okay. So make sure that you present in such a way that don't spend too much time on the sepsis if you want to focus on the infective endocarditis. If you don't know anything about infective endocarditis and rather talk about sepsis, present in such a way that we ask you more about sepsis. Okay. So you can always direct us in a way to ask you that.
Very nicely summed up. Yeah.
Yes, sir.
Yes, Kaladhar.
Yes, sir. There are 1 or 2 questions, sir. When should we add gentamicin? Somebody like Dr. Prasmeet asked about when should we.
So Ampigenta and rifampicin can be given for. Sorry, you want to answer it, Srikanth?
Sir,
intracocci group resistant group of organism, we add either for the native or for the prosthetic, we try to add gentamicin. And
prosthetic streptococcal endocarditis usually add gentamicin. So enterococci and streptococci are the groups, especially in the prosthetic valve endocarditis. Addition of gentamicin has a benefit.
Even for native valve, you will add gentamicin. If it is MSSA, then it would be ampi or cefazoline with genta. And if it is strep, then it would be ceftriaxone with genta. So it's always added. 2 weeks, 6 weeks, 6 weeks. Yeah. The other question is aspirin roll.
The aspirin roll, yes, sir.
To Dr. Rama.
Yeah. So that's one thing I'm glad somebody brought it up. in infective endocarditis, even when they have the septic emboli, there is no indication for aspirin or any anticoagulant for that purpose. Okay. Obviously, you might give them DVT prophylaxis, other things, but from the embolic standpoint, there is no indication if it is an infective endocarditis causing the emboli. So there is no role for us. Somebody has asked about surgery in case of cerebral hemorrhage.
You would have to probably do a craniectomy, right? Depending upon how bad the intracerebral bleed is. Is it a mycotic aneurysm which has bled? Then the prognosis is extremely poor. So try to find out the cause, and obviously life-saving measures have to be done.
And the last question I see here is, how safe is it to remove cardiac devices? Depends, like see, when you say cardiac devices, if it's a pacemaker and the pacemaker lead is infected, the recommendation is not just removing the lead, but removing the entire pacemaker generator, everything, and then replacing with a new one at the right time. Okay. So after giving them antibiotics. So that's what is recommended. I don't know if they're talking about any other cardiac device, but this one for pacemaker for sure, that's the recommendation.
Yes, sir. I think with this, we have done with the session, the questions being answered. Thank you very much, sir, Dr. Khusrav Bajan, sir, and Dr. Ramakrishnan, sir, for sharing your insights and clinical knowledge, and which got so many, especially the students got benefited a lot. And the focused way of how to go forward in the examination, the insights shared are really very informative. And thank you, Yashoda Hospitals and Hyderabad IS CCM for bringing these sessions regularly. And I thank Dr. Srikanth and Dr. Shilpa for bringing this case out and discussing, and which got so many students got the very good informative session. So overall, I thank you all, sir. So good night and take care.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, everyone. Thanks, Rama. Thanks, Kaladhar.
Thank you, sir.
Take care. Bye.
Yes.